Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. This is part 2 for multiple choice questions from external year. So you are requested to like, share and subscribe the channel. So keratosis obturans. What is true about this keratosis obturans? Is it collection of wax and cholesterol in external aortic canal? Is painless? Can easily be removed by ear syringing? It causes erosions and whitening of meatus, and it is associated with otitis media with effusion. So it causes erosion and widening of the meatus. Cannot be removed easily by syringing. It causes pain, and it is not associated with serous otitis media or otitis media with effusion. Again, it is characterized by all except ear canal filled with mass of keratosis. Yes. Widening of bony meatus? Yes, because it causes erosion, as we just saw in the previous question. It needs repeated suction clearance? Yes, because it cannot be cleared in a single sitting, or it may need repeatedly. Leads to facial paralysis? Yes, it can involve the facial nerve, but it is not associated with nasal polypi. So the odd one is D. It is not associated with nasal polypi. A 20 years old male presented with history of conductive hearing loss for last 4 months. There is also a history of sinusitis. On examination, whitish debris are seen in deeper part of external auditory meatus. Tympanic membrane is intact. So when tympanic membrane is intact, it means middle ear causes have been ruled out. So there is a problem in the external ear. So there is whitish debris in deep meatus. So the most probable diagnosis in this case is again keratosis obturans. You can say the relevance of sinusitis is that sinusitis may lead to eustachial tube dysfunction, leading to a bit retraction of the tympanic membrane, quite possible. So due to the negative pressure in the middle ear, the clearance of squamous, outer layer of squamous epithelium, which is being shed repeatedly from the outer layer of the tympanic membrane and the external auditory canal, and this is migratory epithelium, that these flakes are being shed off at the introitus, or the opening of the external auditory canal. So this normal migration of this desquamated epithelium is halted by the negative pressure in the middle ear, leading to the deposition of these whitish flakes there in the deep meatus, which can later on lead to bony erosion and widening of deep meatus. Keratosis obturans is characterized by all except desquamated epithelium. Yes. Wax can be. Cholesterol, yes, but yes, it is not associated with blood. A 17-year-old student joined the swimming class. After 10 days, he got right earache and scanty atoria without any hearing loss. So there is right earache and scanty atoria, but there is no hearing loss, vertigo or tinnitus. There is no history of foreign body or trauma to the ear. Vitals are stable. Otoscopy shows congested external auditory canal with some discharge, but tympanic membrane is normal. There is no obvious swelling or growth. Blood counts are raised with increased neutrophils. Most likely diagnosis is. So when blood counts are raised and increased neutrophils, it means some acute infection is there. When tympanic membrane is normal, it means middle ear infections are automatically ruled out. Only external aortic canal is congested without any swelling or growth. So when there is no swelling of the external auditory canal, it means localized otitis externa or furunculosis is also being ruled out. So what we are left with is congested external auditory canal with severe earache and scanty atoria after swimming and blood count showing increased neutrophils. So this is what we call as diffuse otitis externa. Singapore ear, it results from which of the condition? Again, this diffuse otitis externa, synonymously it is known as Singapore ear. Common cause of otitis externa, it is Otomycosis, that is fungus causing the otitis externa is the most common. Otherwise, we know that we classify the otitis externa into infective group and into reactive group. This infective group includes bacterial otitis externa, which includes localized otitis externa. It is also called, maybe called as furunculasis. Then diffuse otitis externa, as we just saw in the previous questions. Malignant otitis externa. Then there can be fungal, which we call as otomycosis. Viral can be otitis externa hemorrhagica, that we also called as bullous hemorrhagica. Meningitis bullosa hemorrhagica also is the name. And herpes zoster oticus. Then some skin disorders can cause which are included in the reactive group. This can be eczematous, seborrheic, and even some psychological problems leading to neurodermatitis. So this is the whole classification of external auditory canal inflammation. That's what we call as otitis externa. So out of all these different types of otitis externa, the most common one is this otomycosis, that is the fungal, which was being asked in the previous question. So otomycosis most commonly presents with the presenting feature or symptom of otomycosis is itching or irritation in the external auditory canal, along with some pain, discharge, and even hearing loss can be there. But the most predominant symptom is, in case of otomycosis, is itching or irritation, while in case of furunculosis or boil ear, it is pain. Otomycosis is usually caused by, so these are different types of fungi, Candida, Aspergillus, yeast, mucormycosis. So Aspergillus is the most common offending organism in case of otomycosis. Aspergillus. In fungal infections of the nose and paranasal sinuses, again aspergillosis is the most common, and mucormycosis there is the most lethal fungal infection of the nose and paranasal sinuses, while in case of oral cavity and oropharynx, the most common fungal infection is Candida, which we also call as oral thrush. So these are different types of multiple choice questions which can be asked. Otomycosis is responsive to, of course it will be responsive to antifungal agents, and the options, if we see, all are the antibiotic ear drops except this D, which is the antifungal agent, that is the nystatin ear drops. Otherwise gentamicin, chloromycetin, penicillin, and ciprofloxacin, all are the antibiotics. So otomycosis, of course it is a fungal infection, so it will respond to antifungal, that is nystatin in this question. All of the followings are used in otomycosis except, again, all those agents which has got antifungal property, they will be effective against otomycosis, as is the 2% salicylic acid in rectified spirit. Yes, it has got antifungal. 1% gentian violet in alcohol, again it has got antifungal properties, and clotrimazole is antifungal agent. While B, that is the 5% soda bicarb in glycerine, it is used to soften the hard wax, so it does not have any antifungal property. So the odd one here is B, it will not be used in otomycosis treatment. Diffuse otitis externa is also known as, we saw that it is also known as Singapore's ear, as we just saw in a previous question. It is also called as telephonist's ear, because whole of the ear external aortic canal is congested. So diffuse otitis externa, it is also called as Singapore's ear, it is also called as telephonist's ear. An old lady complaining of severe left otalgia, and otoscopy revealed granulation tissues along the floor of the external auditory canal. Blood sugar was 400 milligram per deciliter. Which organism is responsible for her disease? So, first question is that what is she suffering from? So she is a diabetic lady, and diabetes is uncontrolled, isn't it? And she is having severe earache, and on otoscopy there are granulation tissues. So all this fits in what we call as malignant otitis externa or necrotizing otitis externa, isn't it? And the causative organism for malignant otitis externa is Pseudomonas. So instead of asking you a C1 level question directly that what is the causative organism for malignant otitis externa, he has given you the description of malignant otitis externa, that is a diabetic patient in which diabetes is not controlled well, is having severe otalgia along with some granulation tissues along the floor. This is usually at the osteocartilaginous junction on the floor to start with, and later on it can cause the erosion and bone destruction as well. So this is malignant otitis externa, which is basically a pseudomonal infection. So the answer is C, Pseudomonas. An adult presents with acute otalgia with blood-filled vesicles on the tympanic membrane. The diagnosis is malignant otitis externa, meningitis bullosa hemorrhagica, herpes zoster oticus, Otomycosis, and Keratosis obturans. So when this water-filled vesicles, these are usually confined to the outer surface of the tympanic membrane only. So this is what we call as meningitis bullosa hemorrhagica or bullous meningitis. It results from it is a viral infection. This hemorrhagica is caused by, as we saw that it is a viral infection, then which virus? Influenza. It is more common in those areas where there are epidemics of influenza. So to be precise, this is caused by virus, influenza virus, which is uncommon in meningitis bullosa. Seventh nerve palsy, vesicles over the tympanic membrane, hearing loss, otalgia, and atoria. Seventh nerve palsy is not a characteristic of meningitis bullosa hemorrhagica. Seventh nerve palsy occurs in case of herpes zoster oticus, when we call it as Ramsay Hunt syndrome. What does not apply in case of herpes zoster oticus? Herpes zoster oticus is a viral infection, so antiviral drugs cure the disease. Yes. Eruptions occur only on tympanic membrane. No. Here the eruptions will occur which will be water filled, transparent, present on the tympanic membrane, deep meatus, even in the concha of the pinna and upper part of the neck as well. Multiple cranial nerves can be involved. Yes, usually the seventh cranial nerve, eighth cranial nerve can also be involved, and patient of course is having a severe pain, and when those bulli or vesicles they rupture, they are water filled, so the discharge will be watery as compared to the bulli which ruptures in case of meningitis bullosa hemorrhagica. There it is a blood stained discharge in case of meningitis bullosa hemorrhagica. That's why the name indicates, as compared to here in case of herpes zoster it is watery. So eruptions occur only on tympanic membrane? No. Eruptions can involve, in addition to tympanic membrane, deep meatus and pinna and upper part of the neck. With regard to Ramsay Hunt syndrome, the following statements are true except caused by viral infection? Yes. Can lead to brain abscess? No. Facial palsy? Yes. It is a viral infection, so acyclovir, that is an antiviral drug, is effective against it, And of course, steroids, that is prednisolone, can also be used. And yes, it is herpes zoster oticus basically. So water-filled vesicles are there. Ramsay Hunt syndrome, you just to make it say simple, Ramsay Hunt syndrome is equal to herpes zoster oticus plus facial nerve palsy. When facial nerve palsy has occurred in a case of herpes zoster oticus, we can label it as Ramsay Hunt syndrome. So it cannot lead to brain abscess. So with that, we come to end of today's session. You are requested to like, share, and subscribe the channel. And thanks for watching.